Thank you, my lovely Professor Dr. Ain, the head of Clinical Neurophysiology Chapter. Thank you, Professor Dr. Nagia, our guest today. Thank you for your lovely words. Many thanks for Professor Dr. Aya for her great words and for her continuous work and support throughout this course. I would like to start my lecture now. My lecture today is about
share your screen, Dr. Neveen. Share your screen. Share your screen. Share your screen.
My lecture today is about
ممكن دكتورة نيفين ممكن نكبر السلايدز لو سمحتي.
It will be
very good.
Informative, and I hope it will be to the point. Just to put some technical points, some standards to know how to deal with a child in our EMG lab and to reach a proper diagnosis. This is our agenda. I will speak about indications, special considerations and technical issues, normative data, common referrals to the pediatric EMG lab. Electrodiagnosis in the pediatric population. Electrodiagnosis in the pediatric population differs from that in adults with respect to the diagnosis, clinical presentations, setups, and normal values. In fact, it is probably easier to describe what is similar between pediatric and adult studies than what is different. The instruments, electrodes, are similar, but the latter are smaller than those used with the adult. The underlying physiology is similar, but development of the myelin and motor unit is incomplete in the pediatric patient. Due to the developing nervous system, normative data vary, as do the presenting abnormalities. The pediatric electromyographer must have an extensive knowledge of growth and development and a familiarity with pediatric differential diagnosis. EMG is a useful diagnostic tool in children suspected of having acquired or inherited neuromuscular disease and complements the advances in molecular genetics testing during the past decade. The technical limitations of performing EMG in children require that the electromyographer should be selective in deciding how to approach the study. In evaluating for generalized processes, examination of one or two extremities is often adequate to narrow the differential diagnosis or in some cases to suggest a specific disorder. EMG may be used to evaluate hypotonia in infants, to assess the severity, localization, and of perinatal brachial plexus injuries, and to distinguish between different possible causes of gait difficulties in older children. In children, EMG may contribute to the diagnosis of many disorders, including spinal muscle atrophy, brachial plexus injury, hereditary polyneuropathy, acquired polyneuropathy, disorders of neuromuscular transmission, myopathy, muscle dystrophy, and myotonic disorders. Electrodiagnostic testing has been used to evaluate children with suspected neuromuscular disorders for decades. With the widespread adoption of genetic testing in the 1990s and 2000, the American Association of Neuromuscular Electrodiagnostic Medicine convened an expert panel to review the literature and to discuss the collective experiences to provide some guidance to performing these diagnostic tests in the pediatric population. This is the task that we go through it, the utility and the practice electrodiagnostic testing in the pediatric population, 2019. We go through it. The indications for ordering electrodiagnostic testing in children have evolved over the decades. The most common diagnoses were spinal muscle atrophy, congenital myopathy, and peripheral neuropathy. But in 2000, a review was published and addressed this issue and recommended that electrodiagnostic studies to be ordered as an early diagnostic study when the diagnosis of congenital myopathy, indeterminate proximal weakness, inflammatory neuropathy, inherited neuropathy, and disorders of the neuromuscular junction were under consideration. They recommend that electrodiagnostic studies be used as a second-tier test for other diagnoses, such as facioscapulomuscular dystrophy, myotonic dystrophy, periodic paralysis, and spinal muscular atrophy. Regarding the use of pediatric EMG here, second to generalized pathologies, in the upper limb, we can see that carpal tunnel syndrome, which is the most common mononeuropathy in adults, is relatively rare in children. But we may find it in the setting of mucopolysaccharidosis. Proximal median neuropathies comprise a more significant proportion of median neuropathies in children compared with adults. Regarding ulnar neuropathy, it is the most common upper limb mononeuropathy in childhood and is associated with both axonal and demyelinating physiology and is often caused by trauma, compression, and entrapment. The final major upper limb mononeuropathy, radial neuropathy, has similar common etiologies of trauma, compression, and entrapment, generally with a good prognosis. In contrast to adults, radial neuropathy in childhood does not typically localize to the spiral group. The posterior interosseous nerve and the distal main radial trunk, they are common sites of injury here in pediatric age group. Regarding the lower limbs, sciatic neuropathy in childhood has been associated with trauma, iatrogenic causes, compression, various tumors, including perineuroma, and sometimes has vascular causes, including occlusion of the inferior gluteal artery. The other major mononeuropathy in the lower limb, fibular peroneal neuropathy, has been associated with compression, trauma, and entrapment. And one cause of compression of the fibular nerve is osteochondroma at or near the fibular head. As in adults, fibular neuropathy in children is frequently associated with axonal and fascicular injury. There is ongoing debate in the literature regarding the utility of electrodiagnostic studies in the setting of neonatal brachial plexus palsy. Some surgeons argue that electrodiagnostic data do not add meaningfully to the information obtained by means of history and physical examination. However, a survey of peripheral nerve surgeons found that a majority request electrodiagnostic studies before surgical intervention. So many surgeons and electrodiagnostic physicians would likely agree that electrodiagnostic studies play a role in the evaluation of neonatal brachial plexus palsy, but that electrodiagnostic data should be placed in the context of the entire clinical evaluation and not interpreted in isolation. We'll shift now to the second section, special consideration and technical issues, which is the most important part in our lecture. Too many factors should be considered. We should put consent into consideration, how to define the test to the child and to the guardian, how to minimize pain, nerve conduction studies stimulator, how to put them, electrodes, some selected nerves, how to select the nerves to study them in the pediatric age group to reach the proper diagnosis, the use of late responses, some special techniques. Then we'll shift to the EMG needles. We'll speak about selected muscles, why we choose some muscles to work on to reach our proper diagnosis. And lastly, we'll speak about the effect of temperature. First, The pediatric laboratory must have space and seating for 2 or more parents or caregivers. Parents or caregivers should be with the child. It is important for the physician to understand methods of obtaining informed consent for electrodiagnostic testing. Sometimes some labs ask for consent. As in adults, a brief history and the focused physical examination is critical in directing the test performance, especially because they may be terminated prematurely. We may terminate the test prematurely before finishing all what we have to do, all selected nerves and all selected muscles. So we have to put into consideration our provisional diagnosis. If the child is old enough to understand the procedure, it is important to explain it to the child as well as to explain it to the parent. How to define the test for the child or for the parent? It is sometimes possible to convince younger children that the EMG machine is a tickling machine for nerve conduction studies. We have to use optimum vocabulary. For example, electrical pulses rather than shocks, wire probes rather than needles, or we may say the needle itself can be described as a microphone, as sound comes from it, so we can convince them that it is a microphone. Infants may be more comfortable sitting in a parent's lap. We have to let the child in a comfortable position, not for working only as electrophysiologist, but to let the child be calm to continue my examination. So sitting in a parent's lap, on the examination table, or in a chair. Pacifers and toys are often effective in calming the infants and the toddlers. Even school-aged children and adolescents may feel more comfortable if a parent sits or stands near them during the study. A variety of technical factors impact the performance and the interpretation of pediatric nerve conduction studies and EMG, and it is important to appreciate these concepts to provide appropriate interpretation data obtained and arrive at a correct diagnosis. First, we have to minimize pain and discomfort. After the child sitting calm in the laps of his parents, we have to minimize pain and discomfort for the patient. It is of the critical importance in pediatric electrodiagnostic testing. In most cases, starting with appropriate sensory nerve conduction would be optimal. Why? Sensory nerves frequently require lower levels of stimulation, and pure sensory nerve stimulation does not produce a muscle twitch. Longer intervals between each individual nerve stimulus, even when building towards supramaximal stimulus, all of these help children to tolerate nerve conduction status. In small children, toddlers, and infants, stimulation above 50 milliampere is rarely needed. Increases the stimulus intensity to the next should be limited to approximately 5 milliampere. We shouldn't increase it by 20 milliampere. No, it should be gradually by 5 milliampere. Minimizing the number of supramaximal stimulation also helpful. Avoiding unneeded anxiety-provoking explanations, providing support from childlike professionals, and appropriately supported parents. All of these will help us and will help many children to tolerate the procedures without requiring pharmacological intervention. So we can help the child by providing pleasant distraction in the form of music, videos, playful interaction, movies. Distraction, ideally with the assistance of a child-like specialist, has been found to be effective at reducing the pain and should be used whenever practical. Several pharmacologic options also exist to accomplish this goal. Topical anesthetic preparations, subcutaneous lidocaine injections and needle-free lidocaine jet injection systems have been used at various centers. Another alternative pain reduction method is a commercially available device that combines an ice pack, you can see ice pack, with mechanical vibration. This device has been reported to reduce pain from needle insertions, including intramuscular injections and other procedures. And it is widely used by pediatricians for immunizations, venipuncture, and this device is used by some pediatric electrodiagnostic physicians for EMG electrode insertions as well as for other injections, for example, botulinum toxin. So high frequency vibration here, plus freeze hard ice pack vibration with very cold, all of these will cause instant pain relief. And it is very nice for the child. He will like it, I think so. Its shapes are very nice and familiar with children, so it will help them to tolerate and to be comfortable. In addition, ages between 18 months and 5 years are frequently the ones when non-compliant behavior is at its peak. In consideration of the above, conscious sedation and or general anesthesia are used in some centers to facilitate neurophysiologic testing at this age. While many anesthetic agents depress central activity and reflexes like electroencephalographic background, rest, cortical evoked potentials, blink reflexes, itch reflexes, and F responses, but they do not impair peripheral motor and sensory nerve conduction. Deeper levels of anesthesia clearly inhibit voluntary movement. However, the use of combinations such as ketamine and midazolam or nitrous oxide and midazolam, they allow children to move intermittently or in response to reflex activation, allowing analysis of motor unit recruitment and the characteristics. So imagery will be our obstacle. So they have to choose a combination just to help the child to move, to reflex activation motor units of his muscles. Sedation has the advantage of permitting the study to be performed without upsetting the child, but the limitation is a reduced ability to volitionally activate many muscles to evaluate motor unit activity, and also the risk of anesthesia in a child also needs to be considered, particularly if there is severe pulmonary or cardiac involvement. So in sedated studies, and in addition to standard nerve conduction studies, two muscles in the legs to be sampled. For example, we choose tibialis anterior, internal hamstring, and in the arm, we choose biceps brachial. These muscles are chosen because they are the easiest to activate in a lightly sedated patient. So, in sedated patients, they are selected. Muscles, particularly in the hand, are more difficult to activate. So, in the leg, we choose tibialis anterior and internal hamstring. In the arm, we choose biceps brachial. Our first item was how to reduce the pain. Second item, in our technical considerations, we should put into consideration the stimulator. Standard adult nerve stimulators, they generally have a distance of 3 centimeters between the anode and the cathode. And these are generally acceptable for patients above the ages of 18 to 24 months. But in younger patients and in toddlers, stimulators with shorter distances between anode and the cathode, as little as 0.5 centimeters, are preferable. For nerve conduction studies performed on children, it is also preferable to use a stimulating device that allows the examiner hand to encircle the limb. You have to encircle the limb to be able to do the examination for the child, and in the same time, the child will not make vigorous movements that may contaminate our responses. So we are searching here for preferable stimulating device that allow the examiner hand to encircle the limb being studied while simultaneously holding the stimulating electrode. Small bar style stimulating electrodes are ideal for this purpose. Due to the shorter limb length in the pediatric patients as compared to adults, it is not always possible or preferable to use stimulator to recording electrode distances that have been standardized for adult patients. For these reasons, it is often necessary to use anatomical landmarks and not standardized distances to determine stimulation site. For the same reason, recording to reference electrode distance, which is standardized at least 3 centimeters in adult sensory nerve conduction studies, may need to be modified for pediatric population or pediatric patients also. The adult bar style recording electrodes with fixed inter-electrode distance are not practical for some pediatric nerve conduction studies, as we said. The initial stimulation should always be less than 10 milliamperes. And it can be very reassuring to a child when the first stimulation is barely perceptible. Okay, this is the stimulation. We shift now to the electrodes. Standard size reusable electrodes are insufficient recording over very small surfaces, as it is often required in pediatric nerve conduction studies. Most disposable stick-on electrodes can be cut. We can cut it to allow for smaller recording surfaces. We are searching for a smaller recording surface, so you have to cut it, and making them a necessity for pediatric nerve conduction studies. In infants, the most difficult aspect is sensory response, median antidromic sensory. Why? Because it involves the placement of active and reference electrodes where we place them on the second digit. So we can come over that either by putting the active electrode over the second digit and the reference over the third, or the electrodes can be cut in half and both placed on the second or third digit. Or if it is unsuccessful, we can use here, as we see, ring electrodes may be used instead, and the stimulation site as usual as the rest. Also, for sure, the sensory nerve conduction studies represent the main obstacle in nerve conduction studies in pediatric age group. First, we came over the median sensory nerve conduction studies. Second, we can see that the surface recordings of sural nerve sensory action potentials are often obscured by artifacts caused by high skin impedance and short inter-electrode distances. So, in this age group, the most technically reliable sensory study to obtain in the lower extremity is orthodromic medial plantar study, recording the tibial nerve or the medial plantar at the ankle and stimulating, as we see here, and stimulating the medial plantar region of the source. Okay. Now, regarding the morphology of pediatric sensory responses also differ from the morphology of the adult responses. It is of bifid morphology. The first peak representing fibers having already been full myelinated. Second peak, or this bifid morphology, can be seen between the ages of 3 months and 4 to 6 years. But when maturation takes place, the fibers in the second peak, this is the first peak, and can you see the mouse? This is the first peak and this is the second peak. When maturation or with maturation, fibers in the second peak move to the first or to the left and merge with fibers of the first peak to get the proper response or the response that we know in the adult population of one peak only. Okay, now we'll shift to late responses. Elicitation of late responses may produce significant discomfort in a child and shouldn't be performed unless they can help answer to a specific question. So we shouldn't do them in every patient. We should have a goal from them. For example, a child with Guillain-Barré syndrome is a possible diagnosis. When it is a possible diagnosis, so we can shift and we can start to do the late response. If a number of late response studies are necessary, sedation or anesthesia should be considered. If we are doing not more than one or one stimulation, or for example, one F response from the tibial nerve. If I have to do more and more responses to stimulate more and more with supramaximal stimulation, so the child will not be able to be calm in my test, and he may end the test. So in this case, we may need sedation or anesthesia. Despite incomplete myelination, short stature results in F response latencies that are shorter in children than in adults. H reflexes also may be obtained in the upper as well as the lower extremities in the first year of life. We can obtain them, but they are rarely necessary in the pediatric population. Now we'll shift to some special techniques. Actually, they are not different from doing these techniques in the adult group. Repetitive nerve stimulation. Slow repetitive nerve stimulation, 2 to 3 Hertz in children, is performed in a similar manner as in adults. Supramaximal stimulation is delivered as a train of 5 to 10 pulses. The compound muscle action potential amplitude of the first and the fourth or fifth responses are compared, and a compound muscle action potential decrement of more than 10% is considered abnormal. Okay. While this test can provide important information, it is uncomfortable and can be difficult for young children or those with cognitive impairment to tolerate and to cooperate. This must be considered because repetitive nerve stimulation of the facial nerve, in adults we do repetitive nerve stimulation, we rely on it, especially in some cases of myasthenia gravis. In pediatric age group, we have to put into consideration it is particularly challenging and less likely to be performed successfully without sedation or general anesthesia. We also stimulate in front of tragus and will record from nasalis orbicularis oculi as in adults. In suspected disorders of presynaptic transmission, high frequency repetitive stimulation at 20 to 50 Hertz, which yields an incremental response in nearly all such patients. The threshold for determining abnormal facilitation of the compound muscle action potential on high frequency repetitive stimulation is typically considered a 100 increment. On the rare occasion when an older child is suspected of having, but it is rare. In children, it is rare. If he has, or if I'm suspecting that he is having presynaptic disorders such as adult botulism or Lambert-Eaton myasthenic syndrome, a single supramaximal stimulus is given. Then, again, post 10 seconds of maximal contraction of the muscle being tested, this may substitute high frequency repetitive stimulation that the child will not be able to tolerate these very high repetitive stimulation. Because high-frequency stimulation is even more uncomfortable than low-frequency stimulation, this procedure is generally performed under anesthesia in any age group. Sometimes some people cannot tolerate it, really. Abnormalities, we are still in the repetitive nerve stimulation in the special technique. As we said, the technique almost is the same. We have just some points to note about them, to give notes about them. One of the notes here is abnormalities in at least 2 nerves should be identified before diagnosing a child with a disorder of neuromuscular transmission. And this may be difficult in a child who is uncomfortable or uncooperative, but at least 2 nerves. Single fiber imagery, a technique that is used often in adults, is impractical in most children, and if the study is technically inadequate, other diagnostic modalities such as acetylcholine receptor antibody levels and euphonium testing may be considered, or the study may be repeated under anesthesia. For a note, just a single fiber EMG, this is beyond the scope of our lecture, but I have to mention that in children it's called STACE, stimulation potential analysis with concentric electrodes. We use concentric electrodes for that age group. Special techniques, we mentioned repetitive nerve stimulation. We can mention here small nerve fiber testing. Small nerve fibers are thinly myelinated A delta and unmyelinated C fibers that mediate sensations of pain and temperature and autonomic function. Okay. This is cross section here. We can see the A delta and the C fibers here. Sympathetic skin response testing is a simple technique. We can say it is a simple one and can be performed using standard electrodiagnostic equipment and machine, regular one. However, a surface electrodes are placed over the palm and the sole of the feet, as in adults, and can record sympathetic responses to a variety of stimuli. Here, electrical pulses, but we can use tactile or auditory stimuli. However, it is not, it hasn't been validated in children or adolescents. They have been used normally with perceived benefits. Just they do it for research work. Okay. Now we'll shift to the EMG needles and the selection of muscles to be tested electromyography. EMG needles. First, the needle will choose 0.3 millimeter diameter, 1 inch long needles. These needles are referred as facial ones or facial needles. They should be adequate for most needle electrode examinations in the pediatric population. Although it is important that the length of the needle be adequate to pass through subcutaneous fat. Okay, we can use facial needles, but children have subcutaneous fat, more subcutaneous fat. So we have to be sure that we pass it, and it may be prominent in children, especially in infants and toddlers. How to select muscles to do EMG? In a study addressing an isolated traumatic nerve injury, the focus of needle EMG study is directed by clinical examination of weakness and likely nerves involved. In diagnostic studies that assess generalized neuromuscular disorders, the choice and the number of muscles to study is more complicated. So, aim is to optimize the diagnostic value of the study while minimizing discomfort to the child. I have to reduce the number of muscles used to reduce the discomfort to the child. How to make this equation? Sensitivity of EMG in neurogenic diagnoses can be as high as 99.5%. Myogenic disorders are less sensitive. Neurogenic are more sensitive than myogenic by EMG in ages under 2 years, although sensitivity improves in older age groups. Review of the literature suggested that EMG of at least one arm and leg is recommended when feasible. With 4 muscles being optimal for making diagnosis, this allows for sampling muscles in a wide anatomic distribution, but may be limited by patient cooperation. According to the patient cooperation, I can do even 1 muscle in each limb. There is increased perception of pain when more than 1 muscle is sampled and in the upper extremities, including the genioglossus. So we have to put this into consideration. Upper limb and genioglossus, they are painful. Another consideration is the effect of using the smaller pediatric concentric needles instead of standard concentric needles, which may lower the amplitude of the motor unit action potential, but without significant effect over the duration. I use these small needles. It will affect only the amplitude, just a smaller amplitude, but the duration is within normal. With these considerations, it is judges to initially choose the most appropriate muscle to sample. Furthermore, minimizing the number of muscles to be studied is critical to the success of pediatric EMG. In various institutions, some studies are completed with needle electrode examination of only 1 single muscle, based on considerations of expected additional diagnostic data to be obtained with further studies. So we have to wait, and we have to put into consideration the clinical data of the patient, as I may diagnose my patient by only a single muscle, by only a single EMG muscle. Of course, the number of muscles to be tested is dependent on the suspected diagnosis and the clinical presentation of patients, but should be minimized in all pediatric tests. In infants and the toddlers, now we'll shift to the appropriate muscles and to the easiest muscles to be done in this age group. In infants and toddlers, poor cooperation often makes it impossible to evaluate both insertional activities and voluntary activity in the same muscle. In the upper limbs, insertional activity is most easily observed in triceps and first dorsal interosseous. Whereas motor unit activity is better assessed in biceps and in flexor carpi radialis. Because there is a reflexive response to painful stimulus, so the child do flexion immediately. So it is very easy for him it is easy for us to obtain the voluntary activity from the biceps and the flexor carpi radialis. For median innervated nerve muscles, examination of the flexor digitorum superficialis is usually more informative than that of abductor pollicis brevis. Why? Because the infant is more likely to activate the flexor digitorum superficialis. So again, I'll press on these 2 points. In the upper limbs, insertional activity is most easily observed in triceps and first dorsal interosseous. However, motor unit activity is better assessed in biceps and flexor carpi radialis. Regarding the median innervated muscles, it is better to use flexor digitorum superficialis, as it is more likely to activate rather than abductor pollicis brevis. We shift now to the lower extremities muscles. Medial gastrocnemius and vastus lateralis are better for insertional activity. Also, the child cannot move them easily. However, we can rely on tibialis anterior and iliopsoas muscles. They are preferred for motor unit potential analysis. Examination of the cervical paraspinal and the dorsal paraspinal is impractical in most instances. In brachial plexopathy regarding the cervical paraspinal or anterior horn cell disorders in dorsal paraspinal, we don't rely on these muscles as they are impractical really in this age group. As in adults, if there is a question of a polyneuropathy, it is important to examine distal muscles, although it is rarely necessary to study intrinsic foot muscles in young children. Children with possible myopathy should have several proximal muscles evaluated, but one extremity, preferably the lower, should be stirred. Why? Should be stirred because of the histological examination of a muscle biopsy performed. Will perform histological examination, will do a muscle biopsy at a later time. It should be free of potential artifacts from needle injury. So when I'm doing an assessment of a child with myopathy, I have to skip one limb, preferably one lower limb, just to make space or to let to make a muscle biopsy from it. A normal motor unit potential in infants, they are small than adults. In infants, typically they are biphasic, as we see here. Duration here from 1 to 4 milliseconds, and amplitude less than 100 microvolts. Okay, they may, but they are not polyphasic. They may, some will say it is like the myopathic, but actually we'll see at the end or near the end of our lecture, myopathic potentials from a child. Actually, these ones are the normal ones of the child, of infants. Now we'll shift to the temperature effect. Talk about different items, different technical considerations, best technical considerations to be considered regarding our maneuvers. We said that they are concerned with the stimulator, the electrode, the EMG, the needle, the selection of muscles, the selection of nerves. Now the temperature, but it is as in adults. Effect of temperature must be carefully considered in the pediatric age group. Why? Because in normal subjects, within a range that excludes very high or very low temperatures, 1 degree centigrade decrease in local temperature results in a 1.2 to 2.4 meter per second decrease in motor and sensory conduction velocities. Infants may be more susceptible to cooling. Why? Due to their large surface area. And our dear Professor Iman Meher, at the beginning of our course, she gave us a detailed lecture about the technical issues, and she spoke about the temperature effects in detail. Almost the same as children, but some technical considerations should be in our mind in this pediatric age group. Why? As we said, because of infants more susceptible to cooling due to large surface area. Anxious children may have cooler limbs due to autonomic nervous system shunting blood away from extremities. Standardization of temperature during the testing is necessary to obviate this potential artifact. How to do warming for children? Warming may be achieved with the use of towels, damped with hot water and wrapped around the distal extremity for approximately 5 minutes. Care must be taken not to overheat the towel. A child's skin is more delicate than that of an adult and is more susceptible to scalding injury. It is also important to wring out the towel before applying it. Why? To dry the skin after warming. A wet extremity will rapidly cool. So I have to put this into consideration, especially in this age group. However, some electromyographers, they don't use towels. They use disposable hot packs like this, as hot packs that the adults use or for back pain or any other reason. They use these hot packs that produce heat via chemical reaction. If used in children, these packs should be wrapped in towels to prevent burns, for they may become very hot. The temperature should be measured again after warming to confirm that it is in the acceptable range. Now we'll shift to the third item in our lecture, which is the normative data. Normative data also, we can put it in the technical consideration, but normative data should be put in a separate entity because we have too many issues here to say. As too many studies have been done on normative data, and they stratify the age groups into small groups, as we'll see now, several studies that were done. Interpreting nerve conduction studies data for young children must take age into consideration. Why? Because axon diameter and myelination gradually increase from birth until adult values are attained at 4 to 5 years of age. Okay, we have to put this number in our mind. It reaches the normal values 4 to 5 years of age. It reaches the adult values. Whereas a healthy adult is predicted to have an ulnar motor conduction velocity more than 52 meters per second. Ulnar motor conduction velocity for a healthy full-term newborn are expected to be 20 to 36 meters per second, and a premature infant at 25 weeks gestational age would be expected to have velocities towards term values during the third trimester. There is an important issue that we should put into consideration is the subcutaneous fat, particularly in young children, 2 years old, can pose technical, subcutaneous fat can pose technical challenges and can make it difficult to elicit chural and superficial peroneal sensory nerve responses in this age group. So medial and lateral clamp responses may be measured orthodromically in such young children to overcome this challenge. Just we have to mention younger children, 2 years old. Okay, this problem or this obstacle should be into our consideration. The age-related change is due to progressive increases in axon diameter and myelination, and studies reported a steady increase in F-wave latency from toddler years, 1 to 3 years to school entry. Height is the most significant factor influencing the minimum F response latency, more so than age, suggesting that height should be accounted for when interpreting F response latency, especially in rapidly growing adolescents. For younger children whose limbs have not fully grown, our laboratory practice is to use anatomical landmarks. We have to use anatomical landmarks. We have put into in our studies that the distal latency is less important compared with conduction velocity. Why? The distance for stimulation site to recording site is not uniform, and thus the distal latency is less standardized and less comparable. So we have to rely on conduction velocity. Here we can see several studies that have been done and publications providing pediatric normal F responses starting from 1986 till 2019, over the past 35 years. Also publications providing pediatric normal values over different nerves. You can see here the publications starting from 1985 till Ryan et al. Publication 2019, which is the one we are almost relying on it, as he stratified different age groups, and he tested, or he has done too many nerves: median, ulnar, radial, lateral antebrachial, medial antebrachial, superficial fibular, saphenous, medial plantar, lateral plantar. So these studies should be put into consideration, any of us that will work on this age group. Has done normal values and a couple of lower limb sensories. You can see here a sensory, sural sensory, medial plantar sensory with the values, amplitude, the conduction velocities, and distal latencies. And he stratified different age groups from 0 to less than 1 month and so on. (2019) muscle and nerve paper. Also, he has done, they have done ulnar motor nerve. They studied also median motor, ulnar antidromic sensory nerve, and median antidromic sensory nerve. I just wanted to give you here again the study, the name of the paper. You can see it. Nerve conduction normal values for electrodiagnosis in pediatric populations, Ryan et al. 2019. They speculate that the variability in amplitude is because amplitude depends not only axonal features, but also maturity of the neuromuscular junction and the features of the muscles tested. As expected, distal latencies. We speak about distal latencies, they increase with age due to limb growth. However, from birth through 1 to 2 years, the latencies decreased from the effects of myelination. No decrease in conduction velocity as age increases. When age increased, no decrease in conduction velocities were noted in these studies. The mean sural sensory conduction velocity did decrease slightly with age. These are his notes regarding the study. Also, they noted that many nerves reach adult amplitude and the conduction velocity ranges by the 2 to less than 3 year age group, and often by the 1 to less than 2 year age group, with some exceptions. Ulnar, median, and the peroneal motor amplitude increased with age for each group. Regarding the median sensory and ulnar motor conduction velocities, they reached the adult values in the 5 to less than 10 year group, and the median motor conduction velocity not until the 10 to less than 15 year group. This is these values, or these facts, were reported by Ryan et al. Sure, we'll find some exceptions, we'll find some values not exactly the same like this, but almost will try to stick to some normative data task force criteria, as this study, the authors of this study, when they found different, or when they found there is a variability of the normal values of the normative data of the children, so they stated some items to put into consideration in every successive study. they put that the sample size should be more than 100 normal subjects. Subjects should be normal and they should be excluded from any medical illness or like that or something like that. Testing factors use, they have to unify the testing factors, use of digital electromyographic equipment, methods of temperature, filters, and so on, age, distribution of age, statistical analysis, and data presentation. So they stated these items just to make sure that almost the normative data from different papers are almost to the optimum and the same. And we can rely on them on our work, in our work. We will shift now to the fourth section of our lecture, commonly to the Pediatric EMG laboratory. We gave the section of technical issues and normative data. We finished them, and now we'll shift to the clinical section. But we'll speak not in detail, we'll speak in brief. Common referrals to the Pediatric EMG laboratory. Differential diagnosis of hypotonia. Hypotonia, when we are in our EMG lab, we find hypotonia, or the differential diagnosis of hypotonia, usually is the most differential diagnosis in our patients. The differential diagnosis of hypotonia in infancy and early childhood is fast and includes a number of peripheral nervous system processes. However, it is important to remember that the majority of cases of infant hypotonia arise from central causes. Extensive peripheral nervous system should be first only if supported by history and examination. Peripheral nervous system regions may localize to the anterior horn cell, peripheral neuromuscular junction, or muscle. So if a congenital myopathy or muscle dystrophy lies in the differential diagnosis, it is often useful to obtain a set of muscle enzymes before requesting or performing the EMG or muscle biopsy. It is important to remember that muscle enzymes may be elevated immediately after needle EMG is performed. A significant elevation of one or more enzymes will justify a muscle biopsy as the next step. This is a child of 4 years old. Now we'll see this is the deltoid muscle. We can see the EMG here. So can you hear the sound? Is the sound clear?
Yes, the sound is clear.
You can see here early recruitment, crispy sound, polyphasic motor units. Here our parameters over 100 microvolts. Now we shift to brachial plexus. A neonate with birth injury to the brachial plexus may present with a weak or flaccid upper extremity. It is rare for alternative diagnoses to be plausible. Therefore, the question for electromyography usually resolves around issues of severity and prognosis, as we said before. Toddlers and older children may present with delayed milestones or difficulty in walking also. So we have mentioned that the most common diagnosis to come in our electromyographic lab is hypotonia. Now also children with delayed motor milestones or difficulty in walking, as in the evaluation of hypotonia. Differential diagnosis here is broad too, and may include almost any segment of the peripheral nervous system. Proximal weakness often detected by the presence of Gower sign, gait, or both typically suggests the possibility of Duchenne, Becker, or limb girdle muscle dystrophy. If such a patient has elevated muscle enzyme levels. Either molecular genetic testing or muscle biopsy will yield a diagnosis in most cases. When such an evaluation is unrevealing, EMG may be useful in assessing the child for neuropathic process such as spinal muscle atrophy 3. Spinal muscle atrophy 3 may resemble muscle dystrophy with proximal distribution. The same picture of EMG as in adults. We are just mentioning and we are just going through important differential diagnoses coming to our pediatric electromyographic lab. Abrupt onset gait difficulty may be caused by acute inflammatory demyelinating polyneuropathy, inflammatory myopathy, paralysis, spinal cord conditions. EMG may be helpful to distinguish between these possibilities. Chronic gait difficulty associated with areflexia, sensory loss, behavior. Combination of these suggests the presence of an isolated inherited polyneuropathy. Also the same nerve conduction studies and EMG in children almost the same as in adults. The same findings, I mean by the findings. We shift to an important issue, motor neuron disease. Almost the same findings, but we'll speak just about the selection here of muscles, as it is a very important topic. Spinal muscle atrophy has become the dominant anterior horn cell disease. Onset type 1 is typically in the first 6 months of life, and the infants present with hypotonia, weakness, and delayed motor milestones. Examination shows areflexia, hyperreflexia, hypotonia. Tongue fasciculations may sometimes be observed, but are not reliable findings, especially in young infants. And the lack of tongue fasciculation should never be used to exclude spinal muscle atrophy. These children never sit. They never sit independently and never walk. The majority do not survive the second year of life. Second type, from 6 to 18 months, with some cases beginning as early as neonatal period. These children often present with motor delays, and they eventually sit independently but never walk. Gait difficulties are often the first signs of spinal muscle atrophy. Type 3 usually begin after 18 months, and these patients walk independently for most of their life. Life expectancy is normal in most cases of type 3, although some patients require wheelchair assistance as adults. Spinal muscle atrophy is caused by deletion in survival motor neuron gene and chromosome 5q13 until this discovery, where the principal means of confirming the diagnosis, however, genetic testing for deletion is now readily available, but EMG is still helpful in many cases, especially if the presentation is mild or otherwise unusual. As an adult motor neuron, it is critical to document normal sensory response. We'll speak about some notes here, notes, not differentiation from adult EMG, but some notes to put into consideration. First, it is critical to document normal sensory responses. If there are abnormal, the diagnosis should remain a serious doubt. Compound motor action potential amplitudes are often diminished in type 1, but may be minimally reduced or normal in type 2 and 3. During needle examination, at least 3 limbs should be studied. Cranial muscle may be substituted for 1 limb, especially if tongue fasciculations are observed. Examination of paraspinal is not generally helpful here. Both ongoing denervation and chronic re-innervation may be observed. Professor Dr. Lamia Afiti gave a detailed lecture about motor neuron disease in this successful course. So I'm just mentioning some hints in the pediatric HB. In adults, chronic re-innervation should be demonstrated in most muscles of at least 3 limbs to meet criteria for motor neuron disease, but in children it is not always possible to do this extensive needle examination, and any findings should be confirmed by genetic testing. Fasciculation are observed more rarely in spinal muscle atrophy as compared with amyotrophic lateral sclerosis, and the motor unit potential abnormalities are generally symmetrical in spinal muscle atrophy. Here we can see at rest signs of denervation. The child spinal muscle atrophy. He is 3 years old. Now we can see the imagery of gastrocnemius muscle. Here our scale is over 1 millivolt. So the amplitude of the motor unit here exceeding 10 millivolts. We can see a polyphasic and reduced motor unit potential. We can hear the sound. Are you hearing this?
Yes, the sound is very good, Dr. Neveen.
We have finished most important sections of our lecture: indications, special consideration, technical issues, normative data, some clinical overview, and some important common referral to the pediatric EMG lab. Just we will do some brainstorming by mentioning some quizzes here. First, you are performing nerve conduction studies and EMG on a full-term neonate with hypotonia and hyporeflexia. The upper extremity nerve conduction study results are as follows. As we see, median motor, the latency 2.3, amplitude 3.1 millivolt, and velocity 27 meters per second. Sensory, here, as we said, he is not mentioning the distal latency. As we said, we do not rely on the latency on this age group. We rely only on the velocity. The velocity here is 30 meters per second, and the amplitude is 14 microfarads. So you conclude that A, the study is normal. B, patient has a demyelinating neuropathy. C, patient has an axonal neuropathy. D, patient could have either a motor neuron disorder or a neuropathy, or E, electrode placement is deficient. So we're just making a brainstorming now. I can mention, because of time, we are running out of time for sure. I can mention the answer now. The study is normal so far, as because of the age, as we said, we reach the adult values by 4 to 5 years old. So the correct answer is A, the study is normal so far. Second question, while performing needle EMG in infants, it is almost always possible to record information on both spontaneous activity and voluntary activity from each muscle. B, insertional activity best recorded in extensor muscles, whereas voluntary units are best observed in flexor muscles. C, fibrillation potentials and positive sharp waves may often be regarded as normal findings. D, it is important to examine all relevant muscles despite the patient's level of discomfort. E, needle placement is often incorrect because the infant cannot follow directions. So we can solve it by exclusion, just to make it easy. And just to make brainstorming of our lecture. If we say needle placement is often incorrect because the infant cannot follow directions, it is not to answer. It is important to examine all relevant muscles despite the patient's level of discomfort. No, we haven't mentioned that. So we have to select the muscles and we have to put into consideration patient discomfort. Insertional activity is best recorded sorry, I see the C. Fibrillation potentials and positive sharp waves may often be regarded as normal findings. Of course, not true. It is almost always possible to record information on both spontaneous activity and voluntary from each muscle. No, I shouldn't record from each muscle. As we mentioned, we record spontaneous activities from special silent muscles, and we record voluntary activity from other active or extensive or reflexive muscle movement. So the correct answer will be B. Insertional activity is best recorded in extensor muscles. whereas voluntary units are best observed in flexor muscles as it is easy for the child to move it reflexively. Our last question, you are attempting to perform a sural sensory nerve conduction study in a 6-month-old infant. We have to put into consideration here the age, 6 months. But despite several attempts cannot record a reproducible snap. The best course at this point is to move on the next patient, to record superficial perineal sensory, to record softness, or to record medial plantar sensory nerve, or to proceed to the motor studies. For sure, I will not move to the next patient, I will not proceed to the motor studies, but as we mentioned, the sural and the superficial perineal at that age group, they may be affected by the excess fat. So when I do it, I may not gain or I may not get a proper snap. So I have to record a medial plantar sensory response, which is the appropriate or the best sensory response at that age group. Take-home message from this lecture. Imagery and nerve conduction in the pediatric population differs from that in adults with respect to the diagnosis, clinical presentation setups, and normal values. Technical issues in the pediatric age group should be taken into consideration. Interpreting nerve conduction data for young children must take age into consideration. Pediatric electromyographer must have an extensive knowledge of growth and development and a familiarity with pediatric differential diagnosis. And lastly, but not least, from the position and the use of optimum vocabulary